So I am Dr. Nirmal Frederick. With me is Dr. Jignesh Taswala as the co-chairperson and Dr. Gagan Dudeja as the moderator. So I'll welcome the speakers and the participants. So let us, the topics given there, wonderful topics meant for practitioners as well as any ophthalmologist. And we all know the financial planning is very, very important, whether you are in practice or in part of an institution. So let's start with this very important topic on financial planning for beginners in individual private practice. That's a quite focused topic. I invite Dr. Jignesh Taswala to talk to us about pearls for financial planning.
Hello. Yeah, very good afternoon to all of them. At the outside, I would like to thank the Dr. Partha Bishwas and the Aioc Scientific Committee for giving me this platform. Well, friends, as Dr. Nirmal Frederick just said, it's a very important topic, especially for the beginners. I have targeted the beginners because the rest of them are well set practice. So, where do you go? I'm not saying it here, boss. The presentation. Oh, yeah. When I started my practice, I had a lot of difficulties by how to go about it. So today I thought at the age of 63, we put in all the pearls here and see that at least the beginners should benefit with this. Oh, hey, you have loaded the wrong presentation, boss. Excuse me. Can I go ahead with this? Okay. The topics are switched up.
Yeah.
It's a...
Yeah. Okay, there's a slight change in Dr. Jignesh topic. We all know is the past president of Maharashtra Ophthalmic Society. From humble beginning, he has reached this pinnacle of President Maharashtra Ophthalmic Society, and this would be a real motivation for the young brigade to hear his story. So, my life's journey by Jignesh.
Yeah. Thanks a lot, Dr. Nirmal Frederick, the respected chairpersons, and my dear colleagues. Well, as I'm standing here as the past president of the Maharashtra Ophthalmological Society and now the managing committee member of the Aioc, I would like to share my journey. Of course, a lot of people don't try and share their personal this thing, but 60 plus, I thought this is going to be inspirational for the young generation, the young brigade. So here I am. Friends, my school days was very humble. We had just a single uniform which we used for more than 3 years and needed to be altered multiple times till we outgrow the size. Same with the shoes. And also we had only a meal a day to move around because of a lot of financial constraints. The tuition fees used to come through the public provident fund of my dad, who was a salaried person. So the first year of this was my school days. Then I'll jump back directly to the MBBS days. My first year of MBBS in 1977 at BJ Medical College, Pune. My father was the sole bread earner, was in hepatic coma. And there was no signs of survival. We had all called up for the last rites, all our relatives. And then a miracle happened. One of our close physician friends, Dr. H.V. Desai, chipped in and he took him out. See how important is a simple diagnosis which was missed by a previous physician. He was bloating like a sumo pelwan. And just alteration of putting lasting inside, he was drained out, and the third day he was sitting up and having his breakfast. And that is how I am here today. If he had not survived, we would have been doing something else. So then I passed my MBBS in 1982. I got an admission in the MS. Again, I had to fight out that time because a person having less marks was preferred to give the regular seat. So we had to go to Bombay High Court. My father's earnings were meager. We could not match. So I joined Bombay Hospital as a houseman there. and we paid all the lawyers' fees. That time it was around 25,000 by the High Court lawyer. So we tried to manage, and we won the case. And the Pune University was directed by the High Court to have 2 more seats. So again, a struggle at that point. Very important phases of life. There are very little minor struggles every day of life, but this was my changing point. Then my entry in Shankar Nethralaya. Well, Dr. S.S. Badrinath personally used to take interview of new fellows who walked in. And friends in BJ Medical College, even having a slit lamp that time was a luxury. And here they had introduced a pyramidal system where we are kicked out in case you don't perform after 3 months. The evaluation was there, and luckily I sailed through fully. And in fact, Dr. Badrinath was happy, and he offered me a diabetic retinal fellowship extra 3 months. So I did more than a year and 3 months as a fellow. Then I came back to Pune. By that time, my daddy had retired. There was no bread earner again. So the whole load was on me. There were no savings because he had used up all his provident fund to teach us. And friends, to take a loan also, that time we used to ask for guarantors. Now, day in and out, we have maximum calls coming from bank to offer you loan on a platter. Here, being there were no guarantors, one of my school friend chipped in to be a guarantor, and that is how I got the first loan, that for a scooter and to buy simple instruments of cataract and a refraction box. I could not even afford a slit lamp that time. And then I used to move around everywhere out of Pune. I was in Marathi, they call Taswala. Every hour you are at a different place. Of course, that was not a reason my surname is Taswala, but that is how I was told. कि भाई ये साहब every हर घंटे किधर न किधर मिलते हैं. In a vicinity of Pune, about 40 kilometers, I had a Vespa scooter. I used to carry a refraction box and a small drum of cataract. And we used to operate at the periphery and collect 400 as the charges for cataract, and 30 is what we had the consulting that time, out of which the general practice used to take back 10. So at the end of the day, we just used to manage all the expenses. There were no savings to buy the clinic or the house. We are staying in a rental house and a polyclinic where I used to practice. So simultaneously on a personal front, well, this is not to have this thing from you people, ke Baba, it is to show you ke when you are fighting at both the ends and still you try and cross the hardship, how you face the life bravely. I had a lot of family issues. My first wife had schizophrenia, so there was a lot of turmoil in my family during this period, and we had an abnormal child who had a lot of congenital problems and had to undergo 8 surgeries in the first 5 years of life. Simultaneously, they had already filed a case in the family court, and also the criminal court. It was falsely implicating us, so I was fighting the court case just at the beginning of my practice. We came out from the first marriage. I had the second marriage, which was from my own community. Well, she also developed severe bipolar depression, and soon leading to separation. Then my father fell down immediately, and he was bedridden for 5 years, and ultimately had an untimely demise in 2005. My brother, who came to stay, now he had utilized all my father's money. All the corpus, the provident fund, whatever he was remaining, was utilized by my brother, and he also went into huge financial losses, and he came to stay with me. That he had utilized this. Then my mother, who was 75 plus, had paraplegia and was bedridden for 10 years. So we had to keep a 24-hour servant to manage her, and she had morbid obesity, diabetes, hypertension, and recurrent sciatica and urinary tract infection due to an indwelling catheter, and we lost her, unfortunately, in July 2020 during COVID times. Not because of COVID, because of her problems. So financially, I was very heavily drained, repaying loans for my clinic, my residence, medical and surgical equipments, also the court expenses, the lawyer's fees, the alimony to tune of 20,000. That also was retrospective from 2004 for paying for last 17 years. The medical expenses of my ailing father, mother, brother, and of course my child. So I had a lot of mental agony managing single-handedly my own family members with a lot of psychiatric problems, my critically ill and bedridden aged parents, and facing family and criminal court cases, and also managing home and my clinic with no godfather to help. My brother created a lot of ruckus, family discord, and a ruckus in the society, so I had to admit him in mental health care center multiple times, and ultimately lost him again in 2015. My only child is now with me for the last 8 years. Seeing all this, he has also landed up with severe depression, is undergoing psychiatric counseling and treatment. Earlier, court had ordered custody of my son with his wife, and he was there for about 25 years. After that, he came back to me and I was allowed to see him only once a month in the court. Due to his physical and mental problems, he was not doing well in academics. So I told him, as he was pursuing law after about multiple attempts, I told him, you come to my side, do something which I am doing common. So we took him in for optometry, and under my guidance, he passed optometry with flying colors and got a distinction, and now is with me in my center for further training. Now, simultaneously, in my professional fund, after putting 10 years of practice, I had a margin money to take another bank loan to buy my own clinic, surgical equipment and instruments for my residents. And going up the society ladder, became the first joint secretary, then the secretary, vice president, then the honorary president of our local Pune Ophthalmological Society in 2010. Side by side, fighting a family court case in a different city in Baroda, 900 kilometers from Pune, and visiting there every month. Took over as the secretary of the second largest society in India, the Maharashtra Ophthalmological Society, in 2013. Then I had applied for the vice president. Here also, I had to face another hurdle and lost my fought elections and lost in 2018. So there were constant roadblocks with no respite. Then fought another election and won at the home ground of the opposition candidate with a reasonable margin. And during COVID times, of course, everybody had faced this, but instead of repenting the loss of revenue, I started organizing a series of webinars. I think you're all witness to this investment for all the ophthalmologists all over India, with a good viewership of 1,000 plus members, so creating an alternate source for income. Also learned a lot of hobbies too, that is palmistry, feng shui, Vedic astrology. I lost my mother in 2020 during COVID after a long protracted illness. Then came my term as a president in 2021-22. On 30th October, I took up the reins. I started my work 2 months prior. I formed in 21 committees and had already taken the theme as overall wellness of MOS members beyond ophthalmology. Well, no precedent in the history of MOS or any society had formed so many committees now. I worked on a day-to-day basis to see that all committees function optimally, and I had already taken Zoom meetings with 36 presidents and secretaries to be all inclusive. Completed 197 events, an all-time record for not only MOS but any steward society from the 1st of November to 15th of October during my tenure. And of course, we just received the Best State Society Award for more than 1,500 members. These are the committees which I had formed earlier, the mentor-mentee committee, where we had a concept. How much time is there for me? I don't see the timer here. Is it over? Okay.
No, you can. We want to listen to your story, sir. Please go ahead.
Yeah, just quickly go through the personality development and public speaking committees. The LDP committee, again, we had 22 members who are mentored. Diabetic retinopathy committee, young ophthalmology committee, women empowerment committee. They're self-explanatory. Academic committee, yoga and meditation, as my theme was overall wellness. Sports committee, we had zonal and of course finals in 5 zones. Same as for the cultural committee, a grievance committee for all the members with the trade, advocacy committee with the government, and we had added about 700 plus members. Again, a record of membership growth from 2,300 to 3,000 plus is what our membership is. Research, e-library, e-journal club monthly, quiz also monthly with the annual prize money of more than 1,25,000. Financial literacy committee, that is the next talk, in fact, which I'm going to have an idea. Public awareness committee, we had about 15 TV shows and about 50 on the radio programs. Fundraising committee, professional indemnity committee, friends, as you know, a lot of cases going on, and short-term observership committee. Post-COVID also, my clinic and the residence is going for redevelopment, and then again I have to start all over again. So again, there is another hurdle coming up. Simultaneously, I have to look out for the new residents. Getting my son, as I told you, he has got multiple problems to establish me as an optometrist, and also for his marriage is going to be an uphill task. My second wife has now claimed from 20 to 50,000. So that is another case which has opened up a new front. So my go-home message is, don't get bogged down. Have confidence in your own self and have passion in your field of work and be updated. Face problems head on and don't evade or run away or allow them to linger too long. Have a good social circle and have a good network of friends on whom you can fall back upon in crisis. Keep yourself busy. Have some creative hobbies where you can indulge to ward off stressful situations. Be optimistic. There's a silver light. Thank you very much for a patient hearing.
Thank you, Dr. Jignesh. It is a very heartwarming and a true story of any ophthalmologist. And in fact, you must be very tough to face all these situations. In fact, until unless you go to see anybody's house, everybody is having such kind of problems. So, apart from that, you are doing wonderful work in your professional life as well. Thank you so much. And I could not stop you because it was very important to have the mental health issues problem. And in fact, all the ophthalmologists at the age of 50 to 60 should have mental health treatment or management. Thank you so much. And now,
Yeah. So that was a really inspiring story, Dr. Taswala, and thank you for highlighting as well as bringing it to open, because hearing a fellow professional talk, it's really nice to get your views. Thank you. We'll next invite Dr. Rajendra Singh Chauhan to talk to us about banking, the know-how. So the talks are scheduled for 7 minutes each. So I request the speakers to stick to the timings so that we'll have some time for the panel discussions and also take questions from the audience. Over to you, Dr. Chauhan.
Dr. Chauhan. Thank you very much, sir. And good afternoon, respected chairpersons on the dais and off the dais. And I see here all the audience are very senior faculties from all over India. And because I'm involved in banking for the last 20 years, and we are actually training faculties from all over Haryana in banking and keratoplasty. So it is just to give little idea of how bank work. If we look at it, that historical milestones, introduction, burdens, and functions of iBank, requirement of an iBank, and procedures and storage and preservation. Because any institute which wants to open an iBank should fulfill all the criteria, and then a committee need to inspect those criteria, and then they give the permission to start an iBank depending upon the HOTA. And that is why it is very, very important that anybody who wants to open an iBank should have all the little idea about it. If we look at the history, the first iBanking was started in 1937. And then in India, the first iBank in India was started in Aioc, Chennai. Aioc, Chennai, you must have seen it is the 200-year-old RIO in India and the biggest one.
I'm a proud alumni of RIO Chennai.
That is wonderful. Recently, I visited that RIO. I went to the museum also. Yeah. So it is worth seeing place. And in 1960, first successful corneal transplantation was done by Dr. Dhanda in Indore. And then later on, in fact, like 1989, iBank Association of India was formed 1989. And after that, there is a lot of improvement in iBanking and keratoplasty. Now, the magnitude of the problems, everybody knows that corneal blindness can only be treated by corneal transplantation. There are around 2 million people, and out of total blind of India, 25% they are the corneal blind. And new patient every year they keep on adding, and we need actually 1 lakh keratoplasty per year to take care of these things. And this is what is an iBank basically. iBank is a non-profit organization which deals with the collection, storage, and distribution of the donor cornea for the purpose of corneal grafting, research, and supply of eye tissue to other iBanks for ophthalmic purposes. So this consists of like any iBank. It has got some research activity, tissue harvesting, then tissue evaluation. Then they mark the tissue that this is fit for keratoplasty, and then they have to keep this tissue till it is distributed, and then demand is asked and it is distributed. That is all the functions of iBank. In the structure, there has to be 2 sections. One is medical section and one is administrative section. Medical section is basically owned by the medical director, a qualified corneal surgeons, and trained technicians, because they will be looking after the harvesting, collection, and evaluation of the tissue. While the administrative section is also equally important, because they need to have eye donation counselors, training, social workers, health educators, clerical staff, because you have to present those in your different, every month they the data has to be sent to the NPCB, and then it is, as you know, that eyes, that the corneas are neither purchased nor sold, and HOTA is there, so everything has to be in order. So we actually need a good administrative section to look after eye banking. The administrative section will deal with the public awareness programs, liaison with the government, local volunteer, and then the fundraising, because this is the only area why the cornea is lacking, because the cornea has been taken over by the LASIK and Intex and so many other things, and the corneal transplantation and DSEX, they are going back, and that is why very less people are into eye banking, keratoplasty. So fundraising is also an issue, because all these corneal opacities, ulceration, etc., they occurs in usually these patients who are socially and economically poor, from the poor section. The function of the medical section is tissue harvesting, evaluation, preservation, distribution, as I already told you. And then networking of the eye bank under the umbrella of national organizations, like under Eye Bank Association of India, public education programs, institution of newer eye banking procedures, and training programs, and development of the uniform medical standard. So if you look at it, this is a three-tier system. On the top of the tier, there are around 5 eye banking training centers which train the ophthalmologist in eye banking and keratoplasty. Then there are around 45 eye banks, and then the eye donation centers, because they are actually not eye donation centers, they are eye recipient centers. They need to go and inoculate the eyes, and then they send to the eye banks. And there are eye donation center, EDC, eye bank, and eye training center. So the functions of all these three are different. The eye donation center need to only collect the eyes and in the MK medium and send to the eye bank. Eye bank has to evaluate the tissue, will check the blood samples, and once it is found good for transplantation, then they will distribute. The eye bank training center is, along with the eye banking system, they have to train the technicians and the ophthalmologists in eye banking and keratoplasty, because recently, by as per government requirement, minimum 3 months of training in eye banking and keratoplasty is required to start any corneal transplantation center in India. So these are the equipment. If you look at it, slit lamp, specular microscope for tissue evaluation, refrigerator, laminar flow hood, autoclaving, and retrieval instrument. The only thing is in eye bank training center, everything is required. Eye bank slit lamp may not be required. Slit lamp will be required, but eye retrieval center, slit lamp, specular microscope may not be required. But there should be trained people who can inoculate the tissue. Or then the serology lab is also required in eye bank training centers, and tissue processing lab, and instrument for storage and storage medias as well. Manpower is also very, very important. What happens, sometimes we start eye bank without manpower, sufficient manpower, and then we find that it is very difficult to run the eye bank. So these, and the government is also not providing these people, thinking that it is not required. But so what happens, everywhere eye bank is started, and it is part-time job given to everybody. So this is corneal recovery of the retrieval, corneal processing, and then the distribution. That is the function of the eye bank. And eye donation steps, everybody knows that donor selection is done, tissue retrieval is done, corneal examination, tissue transportation, storage of the corneal tissue, and distribution is done. Recently, because in 2020, as per RPC guidelines, negative RT PCR was required, and hospital corneal retrieval program started. And I think that is the most important, because the tissue which is received is of short duration, so the good quality of tissues we receive, and we know the exact cause of death also. So exclusion criteria are depending upon the COVID protocols, and then preparation of the tissue, and this is the whole eye ball is inoculated, or only the in situ corneal scleral excision is done. And this is the corneal scleral tissue is retrieved, and then it is put in the MK medium. The corneal medium is better now, and this is the consent letter. And the blood has to be collected. It is very important, because if the it has to be seronegative, then only we can transplant the cornea. So this is storage medias, everybody knows, and serological testing, biomicroscopic examination is done, and gross examinations, slit lamp examinations, specular microscopy. This is very important because for excellent tissue, more than 3000 cells per millimeter square need to be there. They should only be transplanted. Usually what happens, less than optimal cell density tissue is transplanted and the patient doesn't gain visions. And these are some of the cornea issues which should be taken care of while transplantation. And these are storage medias. And I think thank you so much.
Thank you very much. It was much needed. An overview on how we go about it. Thank you very much, sir. Very well covered. Thanks.
Yeah. So from cornea eye banking, now we move on to the teleophthalmology, reaching the unreached villages. Since Dr. Sanjay has to go to other session, we request him to talk to us about teleophthalmology. Dr. Sanjay Daulat Thakur. Over to you, sir.
Thank you, sir. Good afternoon, everyone. My topic is teleophthalmology, reaching the unreached villages. About 70% of the population of India lives in rural areas, while 70% of the doctors live in urban areas. This is a classical divide, and teleophthalmology plays an important role in bridging this divide and reaching the remote areas. So West Bengal teleophthalmology project was started as a pilot study in two districts of Bankura and Midnapur. 10 centers were selected in each district of Bankura and Midnapur. So a total of 20 centers were included in the study, and there were two nodal centers, Bankura Medical College for Bankura district and Midnapur Medical College for Midnapur district, where all those patients who needed surgeries or investigations were referred to, and for teleconsultation also, which was a synchronous teleophthalmology, real-time interaction between the ophthalmologist and the patient. So initially, a capacity building was done at Regional Institute of Ophthalmology, Kolkata and Vivekanand Mission. Vision centers were established, equipments were supplied, optometrists were trained, not only for refraction but for also slit lamp examination with photography, and internet issues were sorted out for teleconsultation at the nodal centers. So these two districts cover a population of about 26 lakhs, and during this 5-year study about 2,32,000 patients were consulted, and most of these patients, about 40%, required refraction only, and only 6% were referred to the medical colleges. The reasons for referring to medical colleges: mainly cataract, about 7,500, and for retinal diseases which needed investigation, about 1,000. Surprisingly, we also got 66 patients with vitamin A deficiency even now. So now comparing it with other centers, Shankar Nethralaya started this with a customized mobile van which had all the equipments, and ISRO connectivity was provided, and then they also had this teleconsultation facility available and fundus photography facility there. So in a literature published in a journal in 2003, the now figures were that they conducted 6,500 camps, and about 7 lakh patients benefited from this teleophthalmology project. Of these, 25% required refraction only, and about 8% patients were referred for teleconsultation. Arvind Teleophthalmology Network has both vision centers and mobile van. There are 91 vision centers, cover a population of about 85 lakhs, and about 6 lakh patients are examined in a year, and 90% can be fully treated on site. They also have a mobile van from which about 74 screening camps were conducted for diabetic retinopathy, and the prevalence was about 10.5%. So the advantages are we can reach remote inaccessible areas. It saves time, money and the effort of the patient. It provides expert opinion from the ophthalmologist. And a study has revealed that about 26% of the patients were living with potentially sight-threatening diseases without any access to specialized medical care. And this can also be used for screening for diabetic retinopathy, and patients are satisfied. There are some limitations like high cost of initial investment, last mile connectivity of internet, poor quality images because of small people and media opacities. Sometimes the trained staff leave the job. There are policy barriers, medical legal issues also, and you need regular updating of software and hardware. To conclude, it's a cost-effective technology which provides high-quality care to people living in remote rural areas, and very important, 90% can be fully treated on site. Early and timely treatment prevents permanent visual complications and blindness. Due to less time and financial implications, there is improved compliance of follow-up.
Okay.
So initially it was a very neglected area, but after COVID, it suddenly became a star because all the subspecialties had to rely on teleophthalmology to provide services because all the physical services were blocked. So I would like to take this opportunity for acknowledging the contribution of all the staff who provided the technology, all the staff of Aioc Kolkata and Vivekanand Mission Ashram who were involved in capacity building, all the optometrists of the vision centers, and all the staff of Midnapur Medical College and Bakura Medical College. Thank you.
Thank you, sir. It was a fantastic this thing that we have just seen the amount of work that has been done and the people who have got benefited is in lakhs. And 90% did not require tertiary consultation. That is what is a go-home message. So it is the thing that we need to implement all over. Thank you very much. Any comments, Dr. Gagan?
No, sir. For want of time, we'll have to move.
Yeah. So we have the next speaker.
Thank you, sir.
Yeah.
So, just small.
Dr. Arun Sethi would like to come. I think, sir, we are just going to change the sequence. Now we have Dr. Arun Sethi. He's going to speak on reaching the unreached. He's a senior consultant and the director of Deseret Eye Hospital and a very well-known figure all over India. Over to you, sir.
We have very interesting talks and wouldn't like to stop anyone in between, but requesting everyone to please adhere to time limit so that we can finish in time.
Yes. Yeah, I think we have 7 minutes per talk. Yes, sir.
So I'm Dr. Arun Sethi. Thank you very much. Slides कर दीजिएगा. So the two topics that were given, one is reaching the unreached. So this is a little story about how we as private practitioners with a background studying out of Christian Medical College and Arvind Eye Hospital started our own little trust to create an image. So this was started in 1990 and we saw our first patient under a tree when we had the American team visit us and this was in a village near Delhi. And as you can see that we formed only 4 basic objectives. One was to reverse the tide of avoidable blindness, increase eye care awareness in the society where we were working, knowledge and skill transfer amongst our colleagues, and to provide comprehensive eye care because we found there was too much of emphasis in community work only on cataracts. So we designed the eye care project in such a way that before we could build a hospital, we had a village outreach program. We started a school screening program. We had developed 2 vision centers, one in New Delhi, one in Gurgaon, and we had a mobile active ophthalmic unit. Then came up our base hospital, which had a comprehensive eye care and a super specialty clinics, ophthalmic surgeries, and tertiary eye care. So in the pre-COVID area, we used to go out into the village outreach programs and, we would do these activities, including awareness building, training of the local volunteers who would then go and screen the patients before we came to be able to save time, conducting comprehensive. So we were taking glaucoma, retinal diseases, everything into the consideration and providing either free or low-cost glasses wherever it was possible. So as you can see, this is how we used to run those camps. And these are the diagrams of the villages that we were reaching out through various CSR projects, which were sporadic and few, mostly in Gurugram district, where we have now covered quite a few. Then we started the Netra Jyoti Abhiyan. Now, this is the program we are doing with the Gurgaon administration to remove the backlog of cataracts in rural Gurgaon. And our vans are going everywhere, screening them, bringing the patients back where they require surgery. Then another very interesting concept that came up was the school screening program. Here we got a grant from a corporate social responsibility project, and we have the largest series of about 72,000 rural children in Gurgaon district under a project called They See, They Learn. So we used to go in, train the teachers who would screen the students through the e-charts, and then we would go in and screen them again and find out the false positives, and those who required refractive errors, provide them glasses, including the staff. But as per the rules of the government, none of them were undergoing cycloplegic retinoscopy. Those who required the same were referred to our base hospital. So you can see those findings in it. So then we have satellite clinics, 2 of them only. We are starting to see how long they'll take to become viable and the kind of patients who are coming in and getting screened, and we are seeing them over there. Then we are working with primary health centers where our teams are going on a weekly, monthly, or tri-monthly basis to provide eye care services when they're not available. So we already worked in 12 primary health centers across Gurugram district, and we're working closely now with the Gurugram district chief medical officers to provide the same. The post-COVID area was an interesting one that suddenly, masks came in, social distancing came in, we could not have assembly of large number of patients. So we started doing a different program, and as you can see, the vision centers were redesigned to keep space between the patients and to be able to see them. Now that is our base hospital. And the base hospital was designed in the United States, and we now have a cross-subsidy model where one floor is dedicated to bringing in patients from camps and treating them. One floor has subsidized eye care services, and 2 floors are for paying patients who pay, and there's a cross-subsidy model. So that's the look of our private wing, our optical shops, our consulting rooms, our super specialty wing that has been created for diabetic retinopathy, pediatric ophthalmology, vitreoretina, and glaucoma. So we have, the idea is to provide an aesthetic working environment so the doctors feel involved as part of the mission to reach out to the unreached. So as you can see that we have our own scrub rooms, operation theaters, and we provide all the services. So we work with a lot of international organizations over the years, and that is Senator Mitt Romney, who's on our board. He was here from the United States a few years ago. He ran for the presidency of America against Obama and lost. So we have done around 17 lakh patients now, more than 53,000 cataracts, a total about 80,000 procedures we have done. We've given away 95,000 pairs of glasses. So many patients receive free eye medicines. So our philosophy is that the only thing that is worse than being blind is having sight but no vision. So it's important that we should be able to do our practice as well as do community work together. Thank you very much. So there's a second presentation also, which is just 3 minutes.
Actually, you have 2 presentations.
Just 3 minutes, I'll finish that because they transferred it to this hall.
This is only one presentation.
Actually, the other one that they've given me, I've got to. I'll just take 2 minutes.
Okay, sir, okay.
So, वो लगा दीजिएगा जरा. Because the new system which they had was different from the book system, so there was some confusion. So this is how you manage a modern ophthalmic facility, the pearls and pitfalls. So as we were discussing in the previous case, that is very important to have an efficient environment for a modern facility in terms of your staff, patients, and ophthalmologists. So please analyze the goal and expectations of each. If you don't do that, you'll never have a successful practice. In human resources, you'll have to do train staff, technical skilling, upskilling them, task to skill matching, continuing medical education. Now, managing staff performance and efficiency is very important. As you can see, it's important to train your staff. Now, what is the purpose of training? To render better quality services to patients, promoting safety measures. Safety measures are very important because if you don't do them, you are likely to injure the patient unintentionally. Keep an appointment system that is efficiently seeing patients, doctors' time, use HMS and EMR systems. Then the EMR system is integrated information technology, so we use one which is quite effective for our hospital. Then what are the benefits? So if you use modern techniques like this, you reduce the cost and increase the efficiency of the facility. This replaces paper patient medical record become less and you have paperless records, and you can seamlessly transfer them from one center to the other. In terms of marketing, it's very important to establish and maintain customer relationships because your profitability will depend on holding on to the patients you have and finding new patients where possible. So always have good quality eye equipment that you can be comfortable with and provides accurate information. And managing the equipment is also very important. Your frequent breakdowns, cost of maintenance should not go up. And the other thing is that some of the pearls and pitfalls is how you interpret also your findings, because the goal is to balance your capital investment for equipment with the real benefit to patients and increase patient option. Now, if you're running an eye hospital with just cataracts or refractive error problem is in the metro city, you won't survive. It's very important that you have super specialty clinics and good trained super specialists to augment your system. So in conclusion, a modern ophthalmic facility is a service industry with very high expectations of the patients from the physician. Ophthalmologists control major part of the clinical surgical efficiency, and concern and passion for the profession is very important, so don't forget the poor. Thank you very much.
Thank you very much, sir. Dr. Arun Sethi. You have really covered the topic exhaustively, reaching the unreached. It was a fantastic presentation. So also the second one, back to back. Thanks a lot for being part of this very important session. We have the next talk coming up with Dr. Vishal Agarwal, True Color Ultra Wide Field Fundus Imaging Clarus 700. But I think he's not there. So I'd like to invite Dr. Navneet Toshniwal on topics of phaco training for the hospitals. Well, he has written a book on phaco for those who are not aware. Fantastic books, and he's a very good teacher par excellence. He's practicing as a senior doctor in Sholapur and a good friend of mine. Over to you, Navneet.
Yeah. Slides, please.
Sorry.
Unal, na?
Thank you, Jignesh, chairperson, and all the colleagues. Dr. Gopal. The topic is phaco training in hospital. It's a completely confused topic, and from last 25 years, I am in this process of training, because the people just know, I want to come, I want to refresh my hand, I want to do some cases, and I will be all right. So that too, what is the systematic way? What I have started, it may not be the different way, but what I have done, I am just presenting. This is just our hospital. This second building is just the emphasizes by the people who came for training, what they need. What they need, a good hall, good OT. This is the academic hall only for that purpose in the premises. Module of teaching is completely different. In the morning, doctors are observing the cases, then they do 1-2 cases, some steps, then whole day they are not free. They are listening the lectures. I have recorded my 35 lectures on different steps of surgery, and that was also a suggestion of one of the big doctor from USA 15 years before. And they listen the lectures, watching their own cases, and then in the evening we do the analysis. Observation of the cases is the most important part. Suppose today they stuck in trench, next day they observe my cases, how I am doing trench, and the majority of the questions are over. This is the observation. Observation related to the hand movement, observation related to the angulation. Everything they will observe, and then they will ready for the hands-on. So hands-on is every day, but observation and hands-on, if just they will do come at that time and they do surgery, that will not sufficient. Lecture listening and watching their own cases, we give time for them. 2 hours, 1 hour, you have to see your case again and again. Observe your case, and then we can discuss. This is one of the most important topic. Analysis of the cases. I try to give every day 1 hour to with the doctor, with their own cases, and we analyze the cases by watch the videos. Second important thing what I am doing in my practice is the external hand movements we captured by the external cameras. The doctor is not aware of that, how he is holding the phaco tip, how is the angulation of the phaco tip. And all these things are very, very important to give the idea, the correlation of the incision with the instruments. Because many times phacoplegics is not working, there is a leakage like that. So analysis by photography, this is what the Jignesh has mentioned. This is my third book, Do's and Don'ts in Phaco Surgery, is just analyzed by just photograph. We take the doctor's photograph, not only video, photograph. Photograph is a still image. Now if you see the one image that suppose this left side down, my phaco tip is over the nuclear piece. What it does? It can damage the cornea. So such a type of simple tip we try to give with the photograph. So that's the book I have written, third book, Do's and Don'ts in Phaco. Then after COVID webinars, phaco machine discussion. After 3-4 days, we discuss the phaco machine. I don't suggest that you take this machine there. What are the features of the machine they should understand, and they should do their surgery with their own machine. That's the main motto of that. These are some of the books we have written, and recent book is on a phaco machine. These all ideas, I am very much thankful to the doctors who came for training. They are not coming for learning, they are coming to teach me. And that's why I have written these books. And this is the way we run the phaco training program. Thank you for your patience.
Thanks, Navneet. Well, what he has stressed upon is knowing the machine is equally important than knowing the skills. Because if you know the skills and you don't know the machine, you'll end up with more complications. So, fantastic talk as usual. A great teacher, as I just said. Thanks a lot.
Yeah, it was wonderful talk. In fact, this is need of the hour. We need to train our budding ophthalmologist, and because what is happening most of the time, they just read and they just want to perform the phaco. I think this controlled, observational, and under the guidance training is of utmost importance, because every eye needs special care. Every eye is important. We cannot treat them like guinea pigs. So they should be initially they should be trained properly, and then only they should start performing surgeries. I think the mentorship is very important. And if you mentor one resident by one teacher, so that the teacher will be responsible and the student will also be feel attached, he can always ask question. I think this is a wonderful initiation. Being in a medical college, I don't know, sir, about you, but I have heard just Dr. Jignesh was telling me that you are a wonderful surgeon and training, trainer. That is very nice of you. Thank you so much.
We'll have a very important talk. In fact, it's the first talk of the session. Pearls for financial planning for beginners. And anyone who's starting practice, getting a right financial advice is very important. We do have lots of sessions and information available on the practice part and on the ophthalmology part. Over to Dr. Jignesh for this interesting talk.
Thanks, Dr. Gagan, for the kind introduction. At the outset, I would like to again thank the Aioc Scientific Committee and Dr. Partha Bishwas to have given me the platform to talk such an important topic. Well, my target audience, as I rightly said, is the beginners. Well, they know, because I have faced a lot of issues during my initial years. We did not know how to approach this, and a lot of money had gone down the drain. So financial planning, first you need to do a proper budgeting. You need to work out the approximate cost of your infrastructure and instrumentation as a general ophthalmologist in case. And if you are a super specialist, you have to have a proper budgeting of what you are going to go an outright buying of the place and then installing an instrumentation, or you are going for just for a rental clinic or a center and buy basic equipment and take advanced instrument on a rent. If you take a rental clinic and buy all equipment, so these are three options where you have to budget each and everything in this. Arranging the finances. For that, you have to create a proper project report. If bank lends you money, you need to submit a blueprint how your earnings are going to grow over the next 5 years after taking care of expenses. Arrangement of margin money, around 15 to 25% is what is required of the total loan. You have to generate on your own and pay at the time of loan disbursement. No bank gives a 100% loan unless it is personal or an unsecured, wherein the interests are very exorbitant. Margin money comes from your savings, your help from a friend or your relatives and your parents. always go in for a nationalized bank, as the rate of interest is much, much lower than the non-nationalized banks and there are no hidden charges. Go for a moratorium and a staggering payment. Moratorium is a period free of paying the AMI. You may take it for 6 months or 1 year, where you try and establish your initial days of practice. Never take credit card payment. Remember this, they charge 21 to 36% of the rate. Even a 1 day late payment, you will be charged at 26, 21 or 36, depending upon which credit card you have availed of. Don't try to skip an EMI. As the interest starts building up initially, the interest component is much more in the initial years. Remember this, than the capital component. So the more you miss that, you pay more the interest. Always take daily loan on a daily or a monthly reducing balance and not a fixed rate, wherein you pay much more interest. Ask the bank which type are they giving before finalizing. Otherwise, they just give you an EMI chart and you have the least idea of what type of interest they are charging. The list of the nationalized banks, as per the RBI, these are the list. If you can take a screenshot, the SBI, Punjab National Bank, Bank of Baroda, Bank of India, BOM, Canara Bank, UBI, Indian Bank, IOB of Indian Overseas Bank, Punjab and Sindh Bank, UCO and CBI. So these are the banks you should go in and avail this. Now, budgeting, how you're going to do? How much allocation of your income from day-to-day cash expenses for the clinic and EMI, repayment of the loans, how much for the staff salaries, margin money for buying the new equipment. Again, all the insurance you have to keep in mind, the mediclaim, the life insurance, professional indemnity, your utility expenses for telephone, cell phone, MSEB, property tax, professional tax, biomedical waste and a housing loan. Personal expenses and paying income tax. Of course, do file your returns in the very first year of your practice, even if it is nil to start with, because it saves. Because what it gives you is builds your white corpus. Whenever you are going for that 25% or 15% of your margin money, this is going to help you. The savings you should do in on FDs, mutual funds, shares, and golds. Of course, it's a big investment topic which we'll be doing later. How do you reduce your overall cost? So when you're going for buying loans for equipment or for your infrastructure, you need to negotiate. Leverage the suppliers. Buy need and not potential. Their potential पूरा अपने को ये LASIK ले रहा, मैं भी ले लेता हूँ. But whether you have the need for it, whether you have the target people and the consumers for that. Trade time for discounts. Buy bargains. Reduce waste, replace cost to expiry medicines and other consumables. These are very basics. If you follow this, you're going to save a lot of money. Computerized and paperless communication. Of course, Go Green is the initiative, loans from the bank, and of course, the staff management. How are you going to generate your income initially? So that you at your center, you have the OPD consultation, operation, diagnostic, and procedures. Professional income from the institute that you are attached with. Some sources as above, you have the optical shop, the contact lenses, and low visual aids. Generating more surgeries at a discounted rate by conducting free diagnostic camps at the satellite centers once in a month, initially on a Sunday, and that also should be a non-working day, because you should not leave your primary center. Visiting peripheral rural area by conducting outreach eye checkup camps in the rural area once a week, fortnight, a month, thereby having a good surgical inflow from such camps to your main center. It does help. Conducting paid subspecialty training. In case you are a good subspecialist, you can start taking wet labs and tutorial for the general ophthalmologist. And of course, you need to advertise in a different way, in an ethical way, in the newsprint, having lectures, in the NGOs, radio and TV public appearances for a better outreach to the general public and becoming a face in the crowd. Which instrument you need to invest initially? Depends. Again, basics. If you're a general ophthalmologist, you need to work out an OPD chair unit, slit lamp autoref, keratometer, direct, indirect, and tonometer. These are the basics that you have. Rest of the instrument as per your subspecialty. Okay, OT equipment again. If you have cataract is a bread and butter, the phaco machine does come. The chair unit. The Indian ones are very good and highly discounted. Nowadays, they are at par with the international equipment. So you should bargain and take it. Rest of the equipment is as per your subspecialty. OPD and the OT equipment and instruments should be bought in a conference like this, an annual conference where there are a lot of discounts going on for good quality instrumentation. Here, group purchases are good. Now we have seen Dr. Senthil has formed a very nice group for group buying. So that is one of this which you can go. Otherwise, your colleagues, you can form a group and buy. And at individual level, again, you try to negotiate influence of your seniors. Let me know, Gagan, when 2 minutes are left, please. Buy the same product from the vendor company who is trying to establish inaugural offers you get. Then if a vendor is giving good equipment, product and prompt services, recommend him to other colleagues. So at the next time, he'll give you at a discounted rate. Do good market research for your equipment. Best time is the annual conference, as vendors from all over the country are available. See the same product, try and tap as many vendors. One who offers the lowest with the favorable payment terms. They give you EMI, they arrange for your bank loans also. So try and get it at the lowest interest rate with the best of the equipments at a discounted rate. Well, Toyota Motor Company had done a saying is considered the father of just-in-time production. So whatever is required to make frequent deliveries eliminates excess inventory and carrying costs. Like we have IOLs, contact lenses, and surgical items and medicines. The lessons for a smaller center here is not to buy inventory or equipment until you need it. It's very important and determine immediate benefit in either the lower cost or improved patient benefit. Trade time for discounts. Buy in bulk with a condition to pay on using only. I have 100 IOLs. I use 5 this month. I pay only for 5. That is how the payment should go. Some vendors, to reduce the inventory, take this route. As you know, doctors are never defaulters. So you earn and pay with the great benefit of having the full inventory. So advanced inventory costs are saved. Long-term supply agreement over a period of time, you give value for money and great discounted price. Fix a vendor and stick to him over a longer period, so you'll get prompt service and discounted price. Buy bargains. Look for opportunities where discounts are offered. When vendor wants to clear old stocks, new models are coming, he would like to sell off that, and if it is a good product, do buy. In conferences, try and see and buy it at bulk. About 10 people, 20 people buying, you get about 20-25% discount. Also established in newer launches, they try and give it discounted. Closing down the vendor businesses, they sell off this. Annual clearance sale to buy new stocks. They want to clear their own bank loans, so they clear good equipments. Do cash purchases. They always give a discounted if you try and put all the cash down. Reduce waste. Keep a regular tab on your inventory. Tell your staff to check once in a month for small setups. Replace close to expiry medicines, consumables, IOLs, and contact lenses. A lot of wastage is saved in such this thing. Stock only fast-moving consumables and medicines. Computerization, paperless is the in thing which is going on now. We have all the digital media, and Dr. Gopal is also going to speak later on. Email, WhatsApp, SMS are very useful. Wherever feasible, try and use the electronic mode, so you reduce space for the inventory. For each job you need to replace with a machine and computer, the cost comes down drastically. For example, machines do not form unions. They don't go on strike. They don't need health insurance, and they do give work on time. So it's a one-time investment, no monthly salaries. Loan from banks. Take loans only when you need utmost, as higher interest rates have to be paid, higher the loan amount. Check interest rates. Usually nationalized bank offer the lowest. Try prepaying the loan. It's much lower interest than when spreading out over a longer period. Don't spread it out for 10 years just because you have that convenience. Try and pay it off fast. You pay less interest. Always opt secure loans because they give almost 5% less than the unsecured loans. Check the interest rates, whether on reducing balance of which I just said. Staff management. Check your OPD and theatre load. Depending on that, keep the staff. Keep part-time, especially if you are attached to multiple hospitals. Multitasking staff, train them for both the reception, OT work, and counseling, especially nurses. It doesn't reduce the competency as people think. It's not so. Keep incentives rather than increase the salary. So they work hard for you, and your practice is for it. It's an offshoot. Celebrate the birthdays, create a cordial atmosphere and a congenial practice. Then more interest is taken by the staff to develop your practice. Big thank you for having the patient listening. Thank you very much.
Thank you, Dr. Jignesh. Very interesting talk, though it is titled as for beginners, but I believe all of us would have some take-home points from this, and we can already use in our established practice. We are coming to fag end of this session, and now we have back-to-back 2 talks by Dr. Kunal Agarwal. He's going to talk on practice management system and role of AI for increasing patient satisfaction and engagement.
So myself, Kunal Agarwal, I am associated with one of the hospital management software company, that is Easy Solution.
Practice management.
So we are talking on a subject called hospital management system versus EMR. So there's a lot of confusion about the understanding what is exactly an electronic medical record and what is an hospital management system, and are they different or are they same, or what exactly it is. So basically, to clear that thing, the hospital management system is a kind of a primary group, and the EMR or the electronic medical record comes under the hospital management system. So how it works? So nowadays EMR, most of the doctors are very well versed of. It is a systematic collections of the patient complete health records, historical trends of the demographical details, medical history, allergies, immunization details, ocular history, drawing tool, and all other things can come into the EMR. Nowadays EMR can also link with your machines. So all these DICE machines, AR, NCTs, can be integrated with the EMR. So the thing is that you will not make any kind of data entry errors. So if the machine are linked, the data is automatically coming into the software, and the things work out like that. And then the EMR can also serve the patient purpose of patient engagement and patient education. So that we will discuss in the second session, means the next session after that. So these are the some screenshot of the EMR. So we generally have the present complaint, family history, ocular history, past surgery, and all other things. And we can also have the drawing tool. So the problem with the drawing tool we generally encounter is that we have to draw the entire eye or something like that. So nowadays in the EMR we can also have a pre-saved images. So we can just select the pre-saved images according to the different segments and just mark the abnormality or whatever we want to draw on it. And the hospital management system, so it's a comprehensive solution for managing a hospital or a clinic, controlled information management of hospital operations. It can consist of appointment billing, EMR. It can also consist of purchased and departmental inventory management depending on your scale of hospital. It can be for a small hospital. For the larger chain of hospital, they can be a very huge departments where it can communicate through the documents. Even the requisitions, issue of the stock, and everything can be controlled through the software. And we can also control the inventory levels. So we can just mark that what is the minimum level of inventory we should have, what should be the reorder level, so that we should not overburden ourselves by buying excessive amount of inventory as well. Plus we can also have the pharmacy, laboratory, and optical integrated. And the softwares nowadays can also help you on in the audit compliance like NABH and JCI. So in the NABH, it can give you the turnaround time reporting for the OPD, that is a patient journey report, and in the IPD as well. And it can also give you the clinical audit reports. So the NABH asks for you the clinical outcome after 30 days of the surgery. So all those things can also be handled by the software. And the revenue management in-depth analysis and the MIS report in the softwares are very smart enough nowadays. They can automatically send the details. They can learn from your workup and they can send the details according to that. So these are some screenshot of the analysis the softwares can do. These kind of pie charts and the graphical information the softwares can give it to you. And what it can also do is it can improve your patient care, ease of access. It can reduce medical error. It can cost save. It can also adhere to regulatory compliances, improved communication, better resource utilization, informed decision making, case study and research. That is also very important aspect. Like you encounter a special case of a patient, you can just mark them in a case study group, and then you can work on them later on. And also in the patient engagement. So what is the challenges in implementing an hospital management system or an EMR system? Resistance to change, lack of technical expertise, data migration, customization and configurations, interportability, data security, system downtime, and user adoption. So now which one to choose? Generally, this is a question, hospital management system or a EMR. So generally, if you have a very small setup clinic with the OPD load of 10 to 15 patient per day, vision center goal just to focus on e-prescribing and all other things, then you can go for the EMR system. But if you have a OPD of greater than 20 patient, you also have some secondary or tertiary vision center or a chain eye hospital, and your goal is to control each and every department, then you should definitely go with the hospital management system. So the benefit of these is that it will give you a comprehensive solution. It can give you a scalability, like if your practice grows, then it can also tackle that kind of situation. And it can give the improved conversations and the cost effectiveness, as other doctors has also told that EMR or the hospital management system can save on the cost nowadays. And so that's it from this presentation on the practice management system. So I have a next talk about use of AI. So how AI can help, artificial intelligence can help in the patient engagement and the patient satisfaction. So
very nice talk. Just a minute. I just commented. Kunal has rightly covered the EMR part. Friends, EMR is almost a must for every practitioner now. Of course, he's given you all the benefits of how to go about it and how you can use it nicely to see that your practice becomes very simple and smooth. Thank you, Kunal. Go over to your next topic.
So the next topic, I will not reintroduce myself, so I will continue with the talk. So the next topic is role of artificial intelligence in patient satisfaction and engagement. This is relatively a newer topic in a sense that AI is a very hot subject, but very less people exactly know about it, what exactly it is and how exactly it works. So I have kept my slides very short because 7 minutes are not enough for me to talk, but still I will try to touch on few subjects. So that the healthcare industry is undergoing a massive transformation thanks to artificial intelligence. Patient engagement satisfaction plays a key role in a hospital practice or a hospital success. So patients are able to feel connect with the doctors when they receive personalized advice or information, which is very important, because patient want to understand that the doctors knows their condition. So that is very important aspect, and patient satisfaction can be more powerful than any other direct marketing which we do, like a digital marketing or any other marketing. And AI plays important role in learning patient case condition, automatically communicating with patients based on available data. So the AI, what it can do, it can learn about a patient condition, patient case. According to that, the AI can selectively send them a personalized communication. They can send them a personalized informational video, it can send them a personalized information messages, it can send them emails, and then the patient will feel this hospital is taking care of them, but actually we are not doing any extra efforts, that is being handled by the system. And sorry. So what all we can do through the AI? So we can educate the patients by sending automatically the link of your YouTube video that will serve two purposes. That will advertise about the doctor, because you're sending your own videos about the cataract, glaucoma, or any other medical conditions. And to the selective patients, means for to the cataract patient, you're sending the cataract video. It's not like that if a patient has having a refractive errors and you're sending them a cataract video. So the AI will selectively send the details to the patients, and that will be based on the diagnosis, that will be based on the surgery which we have advised, and then it can also send them a feedback links. So the patient can give the feedback, and after that the AI can also react to that. So it's not like that whenever I get a feedback link, so I feel that whether they have taken any action on that or not. So first of all, the AI can calculate the score of the feedback of the patient and automatically say sorry or say thank you. And in general, what we do, if the feedback is good, we send them a Google link or a Facebook link, and otherwise we don't do that. So that's what we can do. And after that, we can also obviously send them an OPD appointment reminder, surgery reminder, and the follow-ups reminder. That is very important, that after 6 months, if the patient has not came back to the hospital, we can just send them a reminder. We can also send them a medicine reminder or these things, but according to their preferences, because even the patient can get irritated by the repetitive messages if we send them. And the WhatsApp integration is very important nowadays, because the WhatsApp has given a direct integrations where we can also send the PDFs, OPD receipts, prescriptions. That will be very handy, because the paper prescription they can lose. Even we are printing it through any EMR software, but if that is going directly on the WhatsApp, then that is very handy. Discharge can directly go on the WhatsApp of the patient, and at any point of time they can search and they can view it. And after that, if they have any question, they can respond back over the WhatsApp, and they can be a bot. So the bot also plays an important role. So bot can be linked with your website, but nowadays people are so lazy that they don't want to open your website. So WhatsApp is a very easy media to do that. And even on the WhatsApp, we do have a bots. So bot can respond to their general query, which we know that we can encounter. It can help them book an appointment. It can help them pay for the appointment. So there are a lot of stuff with a WhatsApp bot can do. And if the patient want a prescription for a particular date, so the bot can help them fetch that details. If the patient want a receipts, so bot can help them in those things. So these are the very important aspects of the AI which doctors should know, and our purpose is to make them learn that yes, the software or the technology has gone so far that without your extra effort, the technology can understand the patient and send the basic things to them. So your efforts are minimized. The tools which is used by AI to communicate is the email, SMS, and the WhatsApp, and also the calls. The calls are now also connected through the technology, in a sense that whatever calls your people are making can be automatically recorded, and your people cannot know about the mobile number of the patients, because that confidentiality is very important nowadays. Because our staff, sometimes they are in one hospital, they are into other hospital, we don't want them to share the mobile number of the patients. So if they have to initiate a call, they can initiate a call from the system, and then that will automatically patch them to the patient, but they will never get to know the mobile number of the agent, or the agent will not be able to get the mobile number of the patient. So that's how the things work out. So that's it from the presentation. If you have any question or queries, then you can very well ask me.
Dr. Kunal, do you own this
Yeah, I own this company,
What
Easy
would-
Solution.
What would be the cost of installation of this?
So
initial?
actually, the cost is very variable nowadays. It all depends on that what model you have, what kind of setup you have. So we have a calculation mechanism through that we quote. So we basically deals in the two versions. Like one is a license based, one is a SaaS based. So license based is like if some doctor has a confidentiality issue, the software can be installed in their on premises, and that has nothing to do with our own cloud. And the SaaS based is a software as a service. It's a rental model where the software is installed on our cloud. That is also secured, but you have to pay a recurring fees. So
Maybe the cloud based, is it costly, expensive?
in a longer run, if you do maths for 5 years, then it's costly. Initially, it's with the lesser investments.
Okay. So do you get the feedback, patient feedback also
Yeah.
through that?
Yes, obviously.
And the positive feedbacks and negative feedbacks also transferred to you?
Yes, in the negative feedback, we generally tend to understand that from which department we are getting the negative feedback, because we put up the questions according to the departments. If the negative feedback is related to the counselor, so the automatically we can register a complaint in the system against the counselor. Counselor has to respond back, or even the counselor has to call back and understand what exactly is the issue the patient has faced. So we can just improve the patient satisfaction. Patient know that I have given a negative feedback, they have called me to understand my grievances, and they've sorted it out. We can just try to sort it out. It's not just for a formality we are taking the feedback. We should work on that feedback, and that is very important. You can see that nowadays hospital engage consultants for the patient engagement and satisfaction, but you should have a tool which should help you out in these kind of things.
Okay, thank you.
Yeah, thank you.
Yeah, please, that's Suresh. Yeah. Please, this one.
Company approached us recently. The John Hopkins University, they approached us for in terms of screening, like community-based screening using AI-based smart glass. They have designed, developed one, smart glass, and not a smart glass, like something like with a camera, high resolution. So the issue comes like data will go to the cloud, and being a government hospital, so we cannot allow them to access the data, our data, to those developer. And second one is the South Korean company. They approached again to me that AI-based smartphone-based screening for refractive error, like in the school. So that AI-based, that smartphone-based that tool, it's very accurate in terms of accuracy, in terms of sensitivity. So again comes data will go to the cloud, and then our administration has a problem. No, we cannot give a permission to use this AI base because your data will go to the cloud, and this cloud that other company they can access. So in the government sector, we face a lot of issues. That means we need to have some kind of our own system. Some of the industry, some developer, they develop some kind of AI-based screening in the community, basically in the community, in the school. Then only we can think of implementing in the government sector. But in the private sector, I'm not sure. So this is a challenge we face now in AIMS hospital. Thank you.
Just to add to that, now also there is a concept like a dedicated servers or a VPS, virtual private servers. So where you own those servers. So you are not dependent on the development company or the IT company. So you own the each and every bit of that. You can have it through the third party like Azure, and if you have the technical expertise or the technical team, you can set up your own data centers. We also have some clients who have their own data center. They're handling 20-30 centers, and that is connected through their own data center. So that is a way you can avoid that dilemma. That as a government you can avoid. Yes.
So in that, so we try to contact our computer facility. They recently, the AIMS, that server has been hacked. So all so there are so many issues come up. So we need to do something. Like now data is so secure, so no one can access the AIMS database now. So that means if we want to have some portion of storage in the cloud from the AIMS server, that again is a problem. So maybe that kind of things like owned by the Indian setup, and then with the due permission from the administration, so we can that way we may plan.
Yeah,
Thank
just
you.
a small thing to add, like Indian government do have their own servers as well.
Correct.
So
That's good.
they
I think with a private server that will not be. So next talk we will go to group practice, one of the a hot topic for the next decade. So it is Dr. Gopal Aurora. So in the present day of cost of instruments, I think group practice is the only way we can start a practice. And day by day, the instrument prices are going up.
A very good afternoon to one and all. Respect to the chairs, seniors, and dear friends. This is what we were being taught in our primary schooling, that a single stick can be broken. But when it comes to a bundle of sticks, it is indeed difficult to break, but on the other hand, it is difficult to carry. What I mean to say is, if you have a group of people, like-minded people, it's easier to sail. And if there is one crooked people, it can even work adversely. So there comes my topic of how you should go about in a group practice. So it's not that old trend of having a 10 by 10 consulting chamber and starting with your practice. Gone are those days. These are the sophisticated days of having sophisticated machines, and you need to upgrade yourself. You need to put in a lot of money before you start any practice. As mentioned earlier by the other speaker, artificial intelligence has come up. But we must remember one thing. For artificial intelligence, we need to have a dedicated team. So an individual working as a solo practitioner, it is difficult to even go into that artificial intelligence theory. So private practice, of course, may yield more profit than group practice in the initial days. But what happens if someone has some untoward incident happening? Right from the 100% practice, it comes to practically zero. So it's a slow build, but it's sustainable. Why do you want to have the stress of investing in infrastructure? And as I said, it's no longer a trend of 10 by 10 chamber. You need to have a state-of-art chamber before you start any eye hospital. Then investing in equipments. Every year, the instrument that you have bought goes into that, gone are those days. So you come up with a new, similar, slightly added advantage of that instrument, and that comes up with some company. Of course, you need to have human resources, EMI, and again, why you want to have the stress of, the improved standard of care. There is increasing competition. I will give us just an example of, in the same building, you have two ophthalmologists sitting just next to each other. This is the trend that's happening in every city. And corporates have not about to enter, but they have entered into ophthalmology. Time management, because you have got only 24 hours. And how do you improve your lifestyle? There can be different ways of having a group practice. One can be a single ophthalmologist with lot many associates. There can be multiple ophthalmologists, or one can have a common list, like an example of LASIK center, where different other ophthalmologists come and operate. But what is a successful group practice? Before even if you think of starting a group practice, you need to drop your ego, because that is the basic of a group practice. Why and what are the advantages? You share the financial, you have a good chemistry. If there's a friendship, that adds to the group practice. You can have higher income potential, different people having different strengths. See, one may be good in finance, one may be good in administration, one may be a good surgeon. So putting in these three things can have a definitely better prospects. Better work-life balance, sharing economy. Individually, definitely we can do less, and return on investment. Even the British Medical Journal has stated that a group practice definitely has got prospects in future. But you need to have few tips. You need to have written business plan. Second, very important point. First three words are important, but the last three words are even more important. So picking up the right person is definitely important, but removing the wrong one is even more important. One of the group practice persons should be a strong administrator. He should be a say person who is going to take a final decision. There should be a transparent profit sharing. The best example I can give you is, if there are three people, then it should be 33% investment, 33% output. Yet, of course, this is a major plus point. You should meet regularly, and workable group practice model is the best that one can expect. See, being a doctor, forget about ophthalmologists. Any two intellectual people getting together is again a different proposition, difficult proposition, but then that is how it works. And again, if you have an improper structure of a group, that can be a blunder. Before, as I said, before you form a group, you need to drop your ego. Similarly, before you form a group, beforehand, in written, you should have an exit policy. Anything can happen, any untoward incident, any accidents, anything can happen. So exit policy should be very much in black and white. Lack of business understanding is directly proportional to our medical profession. Long-term goal, what happens after you? Something happens to you, who is going to take the group practice forward? Office politics, few of your staff take advantage of, if there are 3 decision makers and the person knows that these 3 people are going to take decision themselves, then he's going to take advantage by sharing his view with one of your directors. So it's going to be an office politics which needs to be tackled very cautiously. Ego problems are there, and similarly you should learn from your partner's strength and improve on your weaknesses. This is one of the statements that actually motivated me to start a group practice. And if you don't find a way to make money while you sleep, you'll work until you die. So my dream is, because I've named my group practice as an ABOI institute, I don't want anybody to know Gopal Arora. It is the brand that should be recognized. So these are the few salient features that a successful practice: mutual respect, specialization, defining purpose, adaptation, no scapegoats. One should admit mistakes of what you have done. Patience, ability to delegate, a strong leader. As I said, one should be the person who is going to make the final say. And of course, the competitiveness. So successful brands are an experience. They are not an entity. So one should develop brand, not individual. So just to sum up, coming together is the beginning, staying together is progress, and working together is success. Thank you.
Thank you, Dr. Gopal. Any questions, any clarifications you want?
Sorry? He's an author. I've been following him since long. And I said, when this Warren Buffett, what he says, you work and you earn. That's a common principle of life. But even when you're not working, you earn. That is the basic of group practice.
I think time has come now, the solo practice to go and group practices to come, but it will take a long time. It's too early to predict anything. Thank you very much for giving a nice talk. So I think this session is over now. So we'll leave for lunch, but how many people are left? So all of you please join, we will have a photograph. All of you please join.